All right. Well, good morning, everybody. Thank you for joining me on this Sunday morning. CathEd, we're excited to be giving our third lecture today. We'll be reading angiograms for the ABIM. I know that the cardiovascular medicine board exam is coming up next month, and there's a day 2 coding section, and I think angiograms are definitely a key part. So thank you for joining us today. I hope you find this session useful. I know that many of you are joining us for the first time, so I just wanted to share a little bit about myself. I went to medical school at Northwestern University, after which I went to Cleveland Clinic for my internal medicine residency. I then did my fellowship at Indiana University, and I did interventional cardiology at Beaumont Royal Oak. I'm currently attending in Orlando, Florida, and I took the boards and passed the boards last year. I don't have any disclosures relevant to today's talk. So this is a brief outline. We will look into the ABIM coding sheet. I think it's worthwhile to spend a few minutes kind of dissecting that coding sheet, kind of getting all the information so that on test day, you're not surprised and you're comfortable with the coding sheet. And then the second part and main part of the talk is we'll apply the principles we learned today on reading angiograms that have never before been seen. So just a quick kind of introduction on the ABIM cardiovascular exam. As you all know, it is a 2-day exam. The first day is multiple choice, and the second day is what I call like a practical portion. There's EKGs, echoes, and angiograms. And of course, for today with CathEd, we'll be focusing on angiogram coding. So this is the coding sheet for the ABIM CV boards for the angiogram portion. And so there's a lot of information. And I think it is worthwhile spending some time going through kind of each of these components. So we're just going to take a few minutes to kind of dissect important pieces of information here so that when you're reading angiograms, you're very comfortable using this coding sheet. So the first piece I want to direct your attention to is the red box that I've indicated, the note that the ABIM has put. You must select a description for the degree of the most severe stenosis in each diseased vessel shown. So it's very important to see that they've underlined diseased vessel, and you're just commenting on the most severe stenosis. The reason this is relevant, as we'll see with angiograms, is that if, for example, you're looking at a left coronary system and the LAD has a 90% prox lesion, but the left circumflex is normal, you're not going to code anything for the left circumflex. Again, you're only selecting a description for the most severe stenosis in each diseased vessel. In that case, it would be the LAD. So you would just mark severe stenosis for the LAD. You can see my cursor here. So that's just an important note to take account of. And again, we're going to put it into practice when we read our angiograms. I think another key component here on this sheet is normal. And, I'll admit it was confusing for me even as I was studying for the boards. So the way I've interpreted it is that if you click normal, that means nothing else on this coding sheet is relevant. So you're really only clicking normal if whatever you're looking at, the right coronary, left coronary, both, if whatever you're looking at you think is completely normal, only then would I click normal. It's as if you click normal, the rest of the choices gray out. So that's just something to be mindful of. I think it kind of might be helpful to have had normal as a column here, but the way this coding sheet is constructed, you only click normal if everything you're looking at is normal. So if you even see some mild disease in the LAD, you would not click normal. You're going to click insignificant stenosis here. So just taking a moment, each of the columns has the artery. So left main, LAD, circ, right, and bypass graft. And then each of the rows here has kind of our diseases or diagnoses. And so this first red box that I've indicated, this is very much kind of what we're familiar with. It's basically just saying, is there mild, moderate, or severe disease? And this is something, all of us, through our cath lab rotations have become comfortable as we're doing procedures or we're writing up the reports. This is something we're comfortable with. The thing I will direct your attention to is that it's been arbitrarily chosen that 50% less than that is mild, 50 to 75 is moderate, and greater than 75 is severe. So just take note of that. It's challenging, and I know that you all have experienced it too, that angiography is somewhat subjective. What I think is 80%, you might think is 60 or vice versa. So the boards really doesn't try to give any, lesions that are right in that kind of middle zone. But it's just important to recognize that there is some of that subjectivity. And I will kind of also make the point that I wouldn't get bogged down in the details like, oh, I think this is 60 or I think this is 40. Do I click mild? Do I click moderate? with each case, there's kind of a overarching diagnosis. There's kind of that key takeaway. So I think as long as you're hitting the key takeaway for the angiogram piece, I wouldn't necessarily get bogged down with, I can't tell if this is a 60% or if this is a 40%. So again, just kind of going for that big picture rather than for the smaller details. But it's definitely, there and worth coding. So if you're able to put that, I would certainly do that, but I just wouldn't get bogged down in it. So I think this portion is kind of what we're kind of familiar with. This next piece, I just want to take a second, whenever you're clicking collaterals or total occlusion, these go hand in hand. So you're definitely going to want to think about that. I'll also draw your attention that there is no option here because the left main is never filled by collaterals. It's always the LED or, the circ or the RCA. But these two rows really get at the important point of acuity. So we all know with STEMIs, it's 100% occlusion. There won't be collaterals. It's an acute lesion. But if there are collaterals, then it's probably, subacute to chronically occluded and has been there for some time. So we'll put this into practice, but typically I'd say if you see some collaterals, then you're probably also clicking total occlusion. But if you click total occlusion, there don't always have to be collaterals. And I know that can sound confusing, but once I think we do a few cases, it'll be clear. But I really wanted to kind of highlight these two rows for you because they really go hand in hand. Then I'm not sure why. We're going to jump down here. There's like this potpourri of diagnoses, but just thinking about this coding sheet methodically, the next kind of logical piece is, bypass graphs. And they will want you to mark if you're looking at a graph, is it going to the LED, is it going to the circ, or is it going to the RCA? And I will say for this portion, that's kind of where your views really help. And we'll see it in some cases, but they'll just kind of show you a vessel and you're kind of not quite sure what view you're in. But if you're in an REO caudal and you know that the circumflex is coming kind of on the left side and you see that your graft is attaching to that side, it's probably a bypass graft to the circ. So that would be my advice on when you're trying to figure out, which attachment, where the graft is going. So that's kind of that row. And then the last kind of piece of information that we're pretty comfortable with is the stents. Is it patent or is it occluded? So the other piece of advice I would give is I think we're all guilty, myself included. As soon as the dye fills the coronaries, we're just trying to quickly find like where's the lesion. But I would encourage all of you, before you do that, take a second to look at the x-ray without the contrast. Do you see a stent? Do you see calcium? What are you noticing? Is there staining of the aorta, for example? Because if you do that, then you will be good to pick up, are there stents or not? And I think if you quickly kind of look to see, is there a lesion, you might miss that actually there was a stent there. There's no clear kind of guidelines on coding here, but the way I've coded is basically a stent is patent, even if there's some in-stent restenosis there. And I really only mark it as occluded if it's 100% occluded, as you can kind of see sometimes in STEMI and NSTEMI cases. So that's kind of that. Those are those two rows. And then just the last piece, and that's our whole coding sheet, is this potpourri of diagnoses. So I kind of wish it had been restructured a little bit, but at least we've kind of digested each of the rows. And then these are just, again, kind of the potpourri of diagnoses. Is there spasm? Is there thrombus? Is there myocardial bridging? Is it an anomalous origin? Is it a fistula, ectasia? And of course, is there a dissection? I do think it's worth taking a second to note that there's some empty spaces here. You don't typically, I guess, see left main spasm. You do see thrombus present, but the ABIM has chosen not to put a spot there. You don't really see bridging. And then again, just take a note for the bypass grafts, they've left, bridging the anomalous origin and the fistula blank. And so that's our coding sheet. Again, I hope that piece was helpful. I think it is worthwhile to, just look at it because when you're on test day, you don't really want to be kind of struggling with the coding sheet and finding where the correct options are. So last piece before we will approach some angiograms. I always like to share kind of how CathEd approaches angiograms on the boards. I think the challenge that we face is that, when we're in the lab, we're able to control the camera. We know what view we're in, but the boards, they're going to give you random angiograms. And I think the most important thing that you can do as you're approaching these angiograms is anchor yourself. And the way to anchor yourself is to figure out, hey, what view I'm in. And the way you do that is I would tease apart LED versus circumflex. I think if you take nothing away, I think that would be my pearl here, is that when you're faced with an angiogram and you're not quite sure what you're looking at, identify your septals. Because if you identify the septals, then you've identified the LED. And once you've identified the LED, I think you have a good idea. Am I in a crani view? Am I in a caudal view? And that will help you tremendously. So that's what we're going to practice today, is identifying our LED versus circumflex so that we can then identify what view we're looking at. Once you've identified the view, you just want to make sure you've identified your vessels. You want to identify the lesion, and then what's the diagnosis? What's the point? What are they trying to get across here? What am I trying to pick up? So we are going to kind of put this into repetition for these board-related angiograms. So it might get tedious, but I do think that repetition will just help you put that into practice. And so let's go ahead and read some angiograms on cathed.org. So if you'll allow me a moment, I'm just going to stop sharing here. Give me one moment here. Are you all able to see my screen? Perfect. So this is perfect. So this is our website, cathed.org. We've basically developed courses for fellows, and this is our angiogram coding for cardiology boards. So basically, when I took the boards, I felt like there was not enough practice with angiograms, and I thought it would be a great idea to create a resource for fellows that has more than 100 angiograms with the coding sheet just to gain more practice. So this is a subscription that we offer, and we're going to do some cases through our course today. I'm just going to go ahead and pull this up. All right, so the first case we're going to start is with case 1. So I will draw your attention, the ABIM, and every case of ours does have a clinical vignette. So this is the case of a 68-year-old male coming in with exertional chest pain. I would obviously read the vignette. I don't know sometimes how much it's really helpful. I think that there can be clues there, but I wouldn't put too much stock in it. I would still kind of look at your angiogram. And just as we go through these cases today, if questions come up, please feel free to put them in the chat, and I'll try to get to all questions. And of course, any questions at the end, just don't hesitate to ask. So again, case 1 is a 68-year-old with chest pain, and this is the coronary angiogram. Are you all able to see it full screen?
Yes, we can.
Perfect. So I'll let this play a few times. And again, the questions that you're answering here are, where's my LED in circ? What view is this? What vessels am I looking at? What are the lesions and what is the diagnosis? So I'll let this play a few times here. We're going to play the right coronary here. Okay. Feel free to put in the chat. I'll give all of you a second, kind of what you're thinking based on this. And again, here's our coding sheet that we're using. So with this case, we'll go ahead and start with the left coronary system. Just going to pause it. So what you see here is these are the septal. That's a very large septal, septal, septal. So this is clearly my LED system here. And someone has astutely pointed out myocardial bridging, and we'll discuss that. This is the circumflex here. So this is an ariocaudal shot. If the LED is coming there and the circumflex is highlighted here, this is our OM1 terminating here in the AV groove. This is an ariocaudal shot. And I don't really, I've identified my vessels. I don't really see, this left main looks pretty healthy. I don't see anything here in the circumflex. And then I'm going to let the LAD play here. And I would agree. I think there is some myocardial bridging here. If you notice this, you see these vessels during systole, there's quite a bit of compression. And then during diastole, they're much bigger. I'll let it play again a few times. So I would agree. I think there is some myocardial bridging in this LAD and diagonal system. Just as a reminder, and again, just for board preparation, myocardial bridging, basically the arteries are going through the heart muscle rather than the epicardium. And we do not stent myocardial bridging, but during that systolic compression, you can get chest pain. And so really the mainstay of treatment is beta blockers and calcium channel blockers. Another key point that I just want to make here is just with the way the coding sheet is created, let's just say you only saw it in the diagonal and not in the LAD, you would still mark that I think there's bridging in the LAD. So just remember your diagonal is part of the LAD, your OMs are part of the circ. So they don't have separate columns for that. And so, let's go ahead. So we've looked at that, and I would recommend just as you're reading the angiogram, I would go ahead and start coding. I think it can get overwhelming that to just keep it in your mind and then at the end fill it. So we looked at our left side. We didn't think there was any disease, right? So we're not going to click anything there, but myocardial bridging, yes. I think we saw that in the LAD and the diagonal. Now let's just look at our right coronary. So remember with the right, it's kind of nice. There's typically a LAO, REO shot. This is an LAO of the RCA. And as you can see, the catheter is there. It's a femoral approach. This is nice because the PDA and PLB is split here. Okay. And there is some disease here. I would call this 30%, 40% RCA stenosis. And I'll let that play. But other than that, I really don't see anything. I don't really see any stents. I just see kind of some of that RCA disease. So I think for this case, we come to RCA and we say, I think there's an insignificant stenosis, and then we'll go ahead and submit our answers. And so for our course, each case is annotated with diagrams as well as explanations. So let's pull this up here. So again, there's myocardial bridging in the LAD, there's insignificant stenosis in the RCA. We've kind of shown that here. And then this is a diagram just identifying everything. And here's that myocardial bridging. Okay. That's the first case. And I do see there's a question, are there any ventriculograms or aortograms on the test? To my knowledge, at least on this coding portion, there's not, because there would be nowhere to code it. But it is certainly possible in the multiple choice section that you could get some aortograms, ventriculograms, because they would give you options. But unless they've created a new coding sheet, which they've not, to my knowledge, there are no aortograms, ventriculograms for this portion. Okay, so this would be case 1. We will move on to case 9. Okay, perfect. So here's case 9. So this is the case of a 60-year-old male who's being treated for septic shock secondary to pneumonia. But of course, that troponin is checked and he's found to have a positive troponin. The decision is made to take to the cath lab, and these are the coronaries. So here's the left system. And again, I'll let that play a few times. So again, just remember our approach. Where are my septals? What view am I in? What vessels am I looking at? What are the lesions? And what is the diagnosis? And again, I'll let that play a few times. Give it one more time here. Okay. To you guys to take a look at the right coronary. I'll let that play a few times as well. And feel free, as you all are getting the answers, feel free to put it in the chat. And if not, I'm also happy to just review the answers too. I'll let the right coronary play a few times. Okay, so I'm going to go back here again. As we all know, this is our coding sheet. So let's take a look at this angiogram here. So again, the first step is to identify the septals. And these are our septal branches right here. So you can kind of see the LED is right there. That means this is the circumflex here. And with the circumflex being on the left, this is a ariocaudal shot. So just something to kind of take a note here. In terms of coding for this angiogram, looking at the circumflex, this is a high OM. I do think there's some disease here, but I'm not seeing anything too significant. So I would probably do insignificant stenosis for the circumflex. This left main, I'm not really seeing any disease, but let's take a look at the LED. And again, it can be challenging. This is the ariocaudal shot is not an LED. It's not a shot for the LED, but you can sometimes get a glimpse. And there is some disease there. So there's some LED disease there. And I do see that someone has kind of astutely noted that there's some slow filling, which is a great point. And, in this case, it's possible this person has kind of reduced ejection fraction. We would take a better look at the LED. Maybe there is a more severe lesion in there. Unfortunately, there's nowhere on the sheet to really code for, TIMI flow. But I agree, it's not TIMI 3. But for the purposes of this, I would have said that the LED does not have a significant stenosis, and the circ does not have a significant stenosis. Let's now take a look at the RCA. So I think a lot of you pointed out that there is some disease here. It's certainly not a healthy vessel. So this would be some RCA disease. And I would call that kind of, if you look here, there's definitely some mild disease. The reason I'm calling it mild, I probably would have called it moderate, but the ABIM, right, less than 50%. And I do think that that is a less than 50% stenosis. So I would code that as insignificant. Now, what I'm looking at, and I just want to kind of make sure that everyone picks up, the important point here, which I'm not seeing in the chat, is the RCA has a stent. So remember, don't get distracted by that contrast. I'm going to let it play here again. If you look here, that's a stent in the RCA. And so I would have marked here that the RCA has a stent that is patent. So I would go back to my answer here, and I would say the RCA has a stent that is patent. And so that would kind of be my assessment. We'll pull up some of the diagrams and look like there's some questions there that we'll kind of go through. So again, like we commented, there's this mild disease throughout the RCA. I called it 30% here. And this is the mild LAD disease, mild circumflex disease. But again, this is the point I wanted to make. This is the still frame that I've got. This outline indicates that there's a stent in the RCA. So this is a bit of a tough one. And I do think that one of the hardest parts about the angiogram is picking up on the stents and not being distracted by, all the diseases, all the stenoses. But I do think for this one, if I were a test writer, I think you would get more points for identifying the stent piece than really these small things about is there mild, moderate disease. So a couple good questions. One about kind of overlap with the diag. It's a great question. They don't necessarily always give other shots. So every angiogram is different. They might just show you a couple different views of the left. That's where I think if an ariocaudal shot, I don't think it would be fair to expect some correct or accurate diagnosis of the LED system. So I wouldn't get distracted by that. If you identify that, that's great, but I wouldn't say that that's probably where the meat of this question is, because if that's the case, they would have given you an areocranial and an aleocranial. So I hope that helps. But unfortunately, that's one of the tough parts about doing the angiograms is a lot of times they just give you a view or two views. And of course, that's not real life, because in real life, you're the operator, you're able to control the table and take as many views till you're satisfied with whatever you're trying to diagnose. But again, I think the key question here was about the RCA having a patent stent. Okay. And so again, this description that I've written out here basically goes over that. And again, there's this still frame that very clearly indicates that RCA stent. Okay, so that's case 9. Let's keep doing some cases. All right, this is case 11. So case 11, a 45-year-old male suddenly becomes diaphoretic and complains of chest pain while dining at a restaurant. Okay, quickly get access, and this is what the left coronary looks like. I'll let that play a few times. And of course, not to belabor it, but where are my septals? What view am I in? What vessels am I looking at? Are there any lesions? And what is the diagnosis? I'll let it play one more time. So that's our left system, and this is our right system. Not a lot of coronary to look at here. Let it play one more time. Okay, I'll let you all take a second. I just want to take one moment to, yes, someone wants to see the left system, which is a great thought, and I'll go over that. But there is a question about scoring, and it's a great question. I was actually just reviewing the ABIM guidelines this morning. They don't really say, so I wouldn't take my word for it. I know that when I was studying for the boards, I had heard that if you mark something incorrectly, you might lose a point or two. But unfortunately, I would not take my word for that. And it's not posted on the ABIM scoring because I was just checking that this morning to see. So unfortunately, I would just kind of do your best. Of course, code what you're confident about. And if, something's in the middle, I would just take a stab and just kind of see. Okay, so give me 1 second. Give me 1 second. It sounds like some people are trying to join the lecture. So give us a talk here. Give us a second here. I'm going to share my screen, stop my screen share here. Perfect. Sorry about that. It sounds like some other people are trying to join the lecture, so we were just adjusting the settings on the Zoom here, but we're going to go ahead and continue reading. So yes, some of you definitely pointed out that there is a thrombus in the RCA. So I think I'm just going to let this play here, but the main point that I want to make with this angiogram here is that this is a total occlusion of the RCA. So it's 100% occluded. And when there's 100% occlusion, you want to make sure, are there collaterals or not? Because that will tell you, is this a STEMI or not? Of course, in this case, we also have the vignette, which is telling us that this is an acute issue. It just happened all of a sudden. So I think someone really greatly pointed out, I want to see the left system again. And so as we look at the left coronary system, we're not seeing any collaterals. So I would agree with you all that if I were coding this, I would say the RCA is a total occlusion. And I would say there's thrombus present and there are no collaterals. So that's the RCA. And then for the left coronary system, basically, I'm going to just pause this here. Remember what we said, identify the septals. So here's our big septals. So this is the LED system here. And this is the left circumflex. So this is also an ariocaudal shot. And there is some disease there, and there is some disease here as well. So, and then the left main looks pretty healthy. So basically what I would say is I would code LEDs in significant stenosis, left circumflex is in significant stenosis, and those would be my answers. So let's take a look here. Okay, perfect. So as we noted, there's an RCA thrombotic lesion, and then there's some LED circuit disease. So great question. I personally would code thrombus for the RCA. I do think that, the ABIM will hopefully show some, thrombus is hazy. There's like a contrast defect. But a lot of times with a STEMI situation, you don't see. So I would have coded thrombus here. I mean, this is, I think, an acute lesion. You see that the RCA is kind of, it's got like that beak appearance there. So I personally would have coded thrombus, but I think that's what I would do in cases that are acute and you're not necessarily seeing any collaterals. But there will be cases that they give you that show the clear haziness and the contrast defect, so that will make you be more confident that it's thrombus. But for this case, I would have coded thrombus. So this is a case of an acute STEMI. Let's keep going. Let's do case 44. So case 44 is that of a 50-year-old male with end-stage renal disease. It presents with chest pain and troponin of 1100. And so this is the left coronary system, and you might get some still frames there. Just take note of that. So this is a left coronary system, and then this is the right coronary. So I'll let you all take a look at the left, and then we'll play the right. This is the right coronary system. So for the right coronary system here, I'll just let it play, and then we'll get your thoughts. I'll let it play one more time. So perfect. So let's take a look here. Again, we'll take our approach looking at the left system. So these are the septals. So this is the LED. Okay, this is the circ. Another ariocaudal shot. We seem to have a lot of those. I think there is definitely some kind of mild disease here in the LED. The circumflex looks pretty good to me. But again, I think the meat of the question is here with the RCA. Just taking a look, this is an LAO view of the RCA, splitting into the PDA and PLB. And I think the, very clear answer here is there's a severe disease. That's like a 95% prox RCA lesion. This is a heavily diseased RCA, as you all can see. I'll let it play one more time. So for this one, I would basically go to RCA, and I would say there's a severe stenosis. And for the LAD, I would have said there's an insignificant stenosis. I really didn't see anything in the left main or the left circumflex. And we'll go ahead and submit. So yep, insignificant in the LAD, severe stenosis for the RCA. And this is where we've kind of marked it. See, I thought it was 99 here. So there's a question, can you get TIMI 3 flow? You certainly can, but I would say that, this is hanging on a thread, and that just looking back at this vignette here, yeah, it's an end STEMI. This is an acute lesion, and I think if something is not done, you certainly will have below TIMI 3 flow. But this is a 99% lesion there. So you certainly can still have TIMI 3 flow, but time is of the essence. There's also a PDA lesion here. This is just looking at the left, identifying the septals and then the mild LAD disease. Okay. So let's continue to do a few more cases. I think case 12 is a really good case. So this is a case of a 52-year-old man that has persistent chest pain after shoveling snow from his driveway. And I'm going to let this play for a few. And as you can see, we don't have any right images this time. We just have the left system here. There is a lot to take in with this vignette. I'm sorry, with this angiogram. So again, I'll let it play a few times. And if you guys have a coding sheet on you, I would try to put all the codes, but this one has quite a bit going on. Okay, just gonna pause it here. Perfect. So a lot of you have kind of commented there's some LED disease. There's stents in the LED, stents in the circumflex. So you're all picking up on kind of a lot of key points here. So the way that I coded this, first, let's look at it without contrast. You see this LED stent here. There's actually a stent in the diagonal as well, and I'll show you that on some of the still frames. There's a stent in the circumflex as well. And so we're definitely going to want to code those. I agree. I think there's some left main disease, insignificant. Someone said severe osteo-LAD. We'd probably want to look at it in other shots. This is a good view of the ostium here. I don't think it's severe. I actually marked the LAD as moderate. And the reason I marked it as moderate is looking at here. You see there's some in-stent restenosis in the LAD here. And then let's take a look at the circumflex and the ramus. Or I actually called it a high OM here. If you look here, it's like a ramus, but high OM. This ostium looks very tight. And so I think that there is severe stenosis there. I'll let it play a few times. But and again, an eliocaudal shot would be helpful, but I think it's coming off. I think it's coming off of the circumflex. I think there's a question about severe LAD due to ISR in the diagonal. Let's take a look. This diag is not a very big vessel. It is diseased. I think this is one of those borderline. I don't think it would be inappropriate if you wanted to call that severe, but it's definitely one of those like kind of borderline 70%. So do you call it moderate? Do you call it severe? So I do think that's a great pickup though. So I think let's mark our answers here. So we thought the left main did not have a significant stenosis. The LAD, maybe moderate, maybe severe. I think somewhat subjective. I kind of still think even the diag I would have said is 70, which with the boards is under 75. So I would have clicked moderate. The circumflex, that ostium definitely looked tight. So I would say that that was severe. And we don't have anything for the RCA because they didn't provide us one. But we did have some stents in the LED diagonal and circumflex. And again, we thought that they were patent. So that's what I would code here. I think there is a question if the ABIM has any practice questions. They really don't. I think there's one, they have like a sample case. They do one echo, one angiogram, and one EKG. So there's really not, there's not a lot of clarity. And honestly, that's why that was one of the drivers for me to create this resource, because I thought that the best way to prepare for the exam is practice and just doing as many angiograms, echoes, EKGs as possible. So perfect. So, here's our annotation here. Very clearly see the LED stents, very clearly see the diagonal stent, very clearly see the circumflex. Here's that still frame. So this is coming off of the circ. It's like a high OM, almost like a ramus, but it's severe lesion. I called this moderate. And then, the septal branches and some moderate ISR here. And again, someone in the audience astutely noted that there's some disease here as well. So this was definitely a challenging angiogram, but I don't think it's unlike what you might see on the boards. I think there's a question about no ramus, and that's correct. There is no ramus. I would just look at that and just make sure, is it a high OM or a high diag? In this case, I felt like this was an OM coming off the circ. And again, you might have other views to take a look, but to me, this is coming off the circumflex, not the LAD. But yes, there's no ramus coding on the exam. Okay, so this was a really good question. Feel free to ask any questions about this. I'm going to just go ahead and pull up our next case. I hope that this is valuable. I do think that the coding section, at least for me when I was studying, was one of the parts I was a little nervous about. Through our careers, we've all taken the multiple choice pieces, whether that's through the USMLE STEP exams or our internal medicine boards. But the coding piece was different. And so I do think just all it takes is practice, practice, practice. As far as someone's asking how much time you would recommend, for day 2, the echo the EKG is a separate time, and then echo angiogram is a separate time. So I would just kind of budget, based on how many cases you have, just divide the time by that, and that will give you how much time you should spend. I would say I'd probably spend a little less time on the angiograms and more on the echoes. There's just more information to digest on the echoes. But definitely give yourself, a solid few minutes for the angiograms too. And that's where I think just being systematic and really coding as you read, rather than waiting till like you've looked at everything and then say, okay, I need to code, because that can get kind of overwhelming. So this is case 28. This is a 59-year-old diabetic who comes to the emergency room with epigastric pain, nausea, and vomiting. I'm going to let this one play. This is also a really good angiogram, a lot of details here. I'm going to let this play a few times. And again, I think it's a great example. Where are the septals? Which one is the LAD? Which one is the circ? What view am I in? What are my lesions? And what's the diagnosis? What are they getting at here? I'll let it play one more time. Okay, I'll let you all take a second, take a look at the coding sheet, and then we'll dissect this angiogram. Okay, yeah, this is a bit of a tough one. Let's see, someone thought some collaterals to the right, some moderate left main. Definitely agree with some of those thoughts. So let's take a look here. Let me pause the video. Okay, so where are the septals? These are your septals coming off. So this is clearly the LAD. So this is an areocranial shot. Remember, the LAD is coming off in the front. I know we've had a series of areocaudal shots till now, but this is an areocranial because you've got the LAD. The LAD is clearly severely diffusely diseased. So I would definitely be clicking severe stenosis for the LAD. With the left main also looks diseased. You see this left main that then kind of tapers. So I agree. I thought that there was, more than 50% left main disease here. Now, the circumflex is one that's a little hard here. It's a bit unfair. I don't think you'd really be able to code for it. So if you leave the circ blank, that's fine. Based on what I saw here, I didn't really see any significant disease, but again, it's an areocranial shot. You really can't comment on the circ. So I think either way would be fine. But I do think the most important piece here is these collaterals. And where you see it is here. You see the RCA lighting up there right at the end. And on some of the still frames I've got, you'll be able to see that. But take a look here. You see that the LED septals are clearly filling in this RCA. So a lot of information here, but let's just take a look at our coding. So the left main, we thought that had, so what I would have said is the left main has severe disease because it's more than 50%. And I did want to take a moment to reiterate that this is one of the places where the nomenclature is a bit odd, because I think it's a more than 50% stenosis, so I would click moderate. But clinically, we all know that the left main is not like the other coronaries. 70% is not the cutoff. 50% is the cutoff. So just something to be noted of. Even though you think it's severe left main, you're going to click moderate because it's still within that 50 to 75% reduction. Okay. So the LAD, I would say, is severe. That looked like a 90% lesion to me. The left circ, it's very much up to you. If you wanted to leave it blank, I don't think anyone would penalize you for it, because this is not really a view for the circumflex. And then the RCA, just drawing your attention again to these two rows. Here you see that the RCA is it's filled by collaterals. If it's filled by collaterals, it's occluded, whether that's a subtotal or a chronic occlusion. So just going back to that idea that, if you see collaterals, you're probably going to be clicking total occlusion as well. I think the boards loves this. So this is something I would highly encourage all of you to keep an eye out as you look at angiograms. Be on the lookout for collaterals or to see if they're panning to show you collaterals, because I think that's what they really enjoy doing, is not showing you the right, but based on this one image, we were able to put something for almost every column here. So let me go ahead and submit this and show you some of the still frames, but I think this is a really good angiogram that the boards likes. So again, we see that left main disease there. We see this 90% tubular narrowing in the LAD. Again, the circumflex, up to you, might just let that go. And then you see the septals here. You see this late filling of the distal RCA, and take a look at that. I mean, you can almost see the whole RCA light up by the end of this clip. Okay. So I think, again, this is another involved angiogram that kind of has a lot of different pieces, but if you just go through it step by step, you'll be able to pick up on everything. Just have a couple more cases for you guys. Do case 33 next. Okay. 45-year-old woman with fibromuscular dysplasia who reports to the emergency room with chest pain. These are the angiograms. I think there's a question if you can pause videos on the exam. I believe you can. I think, unfortunately, I don't recall now. I don't know if a lot of us use the mouse to toggle, and to just walk through the images. I don't know if you have that feature, but you can pause them. So we're taking a look at the RCA, and then I'll go ahead and show you all the left coronary system too. Okay. So this one is a bit obvious, and everyone's got it. There's a dissection here in the right coronary artery. And so we'll take a second to speak about dissections, but that is kind of the main point here. If you look at the left system, I don't really see much disease. Maybe you could say some insignificant stenosis in the LAD, but again, I wouldn't scratch my hair, over that. Scratch my head, I'm sorry, over that. I would just say, hey, there's a dissection in the RCA. So that would be the main thing that I would want to say. RCA has a dissection. This one, it's unfortunately, there's really no clear evidence here. I think if you wanted to just mark that would be fine. Technically now it's torn up. There's like stenosis there. So I think if you wanted to say, hey, there's severe disease, I don't think that would be unreasonable. But again, I think dissection is that's the main point here that I would want to get at. Great question. Someone's asking, are the views labeled? The answer is no. So, and that's great feedback for me, maybe for kind of we're constantly adding cases and adjusting this, but maybe for the board course, we should take this out and just leave it for that introductory course that we have, but they will not label the views. So I appreciate that feedback. But I would not take a look at that as you're trying to, I know many of you have bought the course and are doing the cases. The views will not be labeled. So that's why that piece about identifying the septals, so you can figure out which one's the LAD, which one's the circ. Am I in a cranial view? Am I in a caudal view? That's very important. Okay. But again, here's this dissection of the RCA. So, LAD and left main, left circ look good. And then there's a clear RCA dissection here. I do want to take just a moment to speak about dissections, and that's what this description does. Just be on the lookout. Like I said, the vignette, it can be helpful, but it's not always helpful. Pregnant females, people with fibromuscular dysplasia or Ehlers-Danlos, these are people that are at risk for dissections. As you're looking at diagnoses, just keep in mind, like in this case, I think that this person was predisposed to one, but this catheter doesn't really look like it's in the best spot. Those are just those principles that, before you inject, you always want to check your waveform, make sure it's not damped. You want to make sure your catheter is in a good position because you can very, very easily dissect a coronary. Just remember, you can also dissect with guide wires. If your tip is not free, you can be buried in the wall, and that can also be responsible for dissections. And then, of course, just remember that when we're deploying stents, there can be edge dissections distally or proximally. So, if you see any of those things, like let's say there was a stent in the RCA and you saw a dissection there, you might think, hey, maybe this is an edge dissection. So just different things to think about. But I do think in this case, this was a dissection from the catheter. And of course, don't forget about SCAD, spontaneous dissection where artery is completely healthy, and then you have a dissected vessel and then it's completely healthy again. So just some key points. And then I agree. I do think that the PDA has some stenosis. So that would be another reason. And maybe that, I'm just taking a look here. Maybe, yeah, that's not annotated, but there is definitely some PDA disease. So, and I would call that severe. Sounds like there's another question about dissection versus obstruction. Yeah. Again, unfortunately, there's not that clarity because when a vessel is dissected, the lumen is torn, and then there technically is a stenosis because your true lumen is stenosed. So it's one of those that we don't have a lot of guidance from the ABM on that piece, but I would click dissection, and personally, I would click stenosis. And in this case, because of the PDA, it's disease too, so you would code that. So unfortunately, I know that doesn't really answer that question, but there's just really not a lot of guidance. But I think the main takeaway here is the RCA dissection. So I think you would get the points for that. Okay, we're going to do case 26. Okay. A 62-year-old female who has intermittent chest pain when she walks around her neighborhood. And it looks like this one, let's take a look here. So I'll let this one play. This is a little different than what we've seen before, so I'll let it play a few times. Okay. This is the second one. Let you all take a second. I'll let this play and we'll start coding with this angiogram. Okay, great. So this is a tough one in that this is pretty similar to what we see. So I would agree, the LEDs, first of all, where the septals, we really don't see it, but I think we all kind of recognize this as our spider shot. And so spider shot, the circumflex comes here, LED comes here. So, there is some disease here in this left main, some insignificant. Of course, the main point here is that the LED is chronically occluded and the circumflex is chronically occluded. I think some of you are commenting on collaterals. It's possible, it's kind of hard to really tell some of this kind of faint collaterals here. It's possible that it's likely that the circ is bypassed, but we don't see that. But I think the main point here is, this is not really compatible with life, but this person, as you all identified, has a lima. So this lima looks pretty healthy and pretty nice, and it's patent. I don't see any disease there. Now, one comment I will make to you all that, just in kind of preparing for the boards and studying for the boards, sometimes you'll just see a graft, and, I think we all get carried away with coding the graft, but just remember, a lot of times with the graft, you're able to still see the native vessel. And I'm just gonna move this cursor here. And so with looking at the graft, you wanna look distal to the anastomosis, make sure that there's no disease in that LED. So just be sure to be commenting also on distal to the anastomosis. So, here with this, we see that limit LED is attaching here. This LED looks healthy, but you just want to be sure to comment on whatever you're able to see of the native vessel, because ultimately you can't see it, right? So I feel like that's where the boards can get tricky is they want you to code everything you can see. So if you do see some of the native vessel, you will want to comment on that. So for us, we thought the left main had a little bit of stenosis. We thought the LED was 100% occluded. We thought the circ was 100% occluded. We actually thought the bypass graft, the lima, was normal. So that's that one of those differences. You're not going to click anything here because I personally didn't see any stenosis in the lima LED. But you will come down here, bypass graft to the LED. Okay, so that's how I would code this question. I think someone said some staining of the circ. It's certainly possible. I feel like when vessels are chronically occluded like that, it's typically they can typically look like this. And then that's where the vignette's helpful. She's walking around her neighborhood, right? A thrombus in your circ, you're probably going to be presenting as an end STEMI or a STEMI. She's coming in kind of for an elective procedure here. So I would just say that that's a CTO of the circ. And then I think someone said, is there some aneurysm? I don't really appreciate any aneurysm here. We'll do another case where you'll see that. So I personally would not have coded that. But again, I think the main point here is identifying the total occlusions, 100%, 100%, and then your lima. And just looking at that native lima. So someone's asking, when we select bypass graft, do we select insignificant stenosis in the bypass graft? I would not, because to me, this lima looked healthy and I did not really see any disease in the lima. So you're only going to mark something for the bypass graft if you think it has disease. Because again, it's that question, select a description in each disease vessel. The bypass graft is not diseased, so I would not have selected anything. We just have two more cases. Case 29. 65-year-old man who uses IV drugs comes to the emergency room with chest pain and is found to have elevated troponin. He goes to the cath lab, and this is his angiogram. Again, a lot going on in this angiogram, so I'll let it play a few times. Any thoughts on this angiogram? Okay, so I think some people have picked up on some nice points here. So just trying to pause it where we can see. So I do think there's some left main disease. Again, that's probably not the key point of the question. The key point is right here, the severe LAD disease. I think someone was asking about aneurysm and ectasia. This is definitely an ectatic aneurysmal diagonal. So I would have clicked aneurysm for LAD, severe stenosis from the LAD. The circumflex, I think, gets interesting, and it's very subtle, but the circ actually looks to be chronically occluded with collaterals. If you look here, there's some backfill here to the circumflex. And again, I think that, if they're going to expect you to diagnose that, I think it would be unfair to do it on just one angiogram. I think you would definitely have to see other ones. But if you look here, this circ does have late filling, and there are collaterals coming from the LED. So this is definitely a tough one, and I'll let it play a few times. But I do think that the circ is, subtotal to chronically occluded with left-to-left collaterals. So what I would have checked for this one, I would have said the left main, maybe some disease. LED is severely diseased. The LED has an aneurysm. The left circumflex I thought was totally occluded, and there were some collaterals. There's no RCA, no bypass graft. So do you see how if you kind of go, I would definitely go column by column, because, once you click everything for the LED, you're done with the LED, then you read the circ. Once you're done with the circ, you move on to the next one. So I think that's the best way to kind of approach this. And so, like we said, severe stenosis, aneurysm in the LED, left main has insignificant stenosis. And I think this is a CTO here, and there's collaterals to the circ. So this was definitely a tough one, but a lot of great kind of didactic pieces of information in this angiogram. Just have one more for you guys, and then just some concluding remarks. we're going to do case 60. Just want to get everyone's opinion on this one. So this is a 59-year-old female who reports chest pain with activity. I'll zoom in here. Where are the septals? What view are we in? What vessels am I looking at? Is there any disease? What's the diagnosis? I'll let this play a few times here. So for this one, sometimes, to be honest, clicking normal can be the hardest one, but to me, this was a normal angiogram. You see that the LED is coming off on the right based on the septals. Based on our septals here, this is the LED. This is our circumflex. This looks like pretty much a normal angiogram, maybe some luminal irregularities, but I would have clicked normal. And again, you only click normal if you think everything looks normal. And we'll go ahead and submit that. And this is the annotation. So I know it can be challenging because, you almost want to click that there is something. So I would have clicked normal. And somebody asked that question, and that is correct. You don't select normal unless all the vessels are normal. So this is a sample. Again, we did about 10 cases of the 60. There's a total of 100 angiograms in our course subscription. I'm just going to go back to our PowerPoint here for some final remarks. But, I appreciate all of you joining. I think that, like I said, I had wished that there was more angiogram practice. So that's why I kind of created this subscription. I know a lot of you are using the content. I hope you're finding it valuable. Please feel free to reach out with any questions or feedback. Again, we're always trying to, bring new content and course subscriptions to everyone. This is our YouTube channel, and this is our Instagram. And yeah, thank you for joining. Happy to share the recorded lecture. I think some people tried to join, weren't able to join. I will get that recording to them. Any final questions? Someone's asking about a pre and post nitroangiogram to demonstrate spasm. I think they will, and we actually have a case in there. So if those of you who do the subscription, there is a pre-post nitro one. So I think they will definitely try to indicate that to you all. Awesome. Well, thank you everybody for joining.